Welcome to the Pod of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours, get down in the cave, and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
My guest today is Dr. Brian Rothbart. Dr. Rothbart is a fascinating individual who has done a tremendous of work. Unfortunately, it's pretty much all unrecognized or not acknowledged. And after I started looking at this, I felt that it just had to be put on the show because there is a lot to it. And it is very contrary to what has been traditionally taught in the field of biomechanics, but I think there's a lot of merit into it. And for those of you who are open-minded and also skeptical, but always want to take a deeper dive into things, this might be the perfect episode for you. So please enjoy my fascinating conversation with Dr. Brian Rothbart. All right. Hello, everyone. I am very honored to have Dr. Brian Rothbart on today. And we're going to discuss basically what I would call the foot-brain connection, because I think he has a tremendous perspective, has a tremendous amount of work that shows how really interconnected the foot biomechanics are to the rest of the human being, including the central nervous system. So, Dr. Rothbart, thank you for coming on today.
It's my pleasure, and thank you for inviting me.
So let's get started first with you telling us a little bit how you ended up in this space, what we're going to talk about today, because I think your story is kind of interesting.
Well, I graduated from podiatry in 1970 and entered a very traditional practice at that time, basically surgery. And in 1991, a very significant thing happened. I was in a car accident. I was sitting at a light, stop sign, and unfortunately a school bus ran into my car. To make a long story short, I ended up with a neck injury that didn't go away. I saw everyone. I was assured in time it would get better, but in time it kept getting worse and worse. I was losing the use of my hand. I could no longer do surgery because of the weakness in the hand. I was getting more and more neck pain that was radiating down into my back. Finally, I went to a very good neurosurgeon I knew. He looked at me and told me, "You have severe degeneration in C2, C3. We need to go in and clean it up. It should work. Can't guarantee it, but it should work." Unfortunately, I had a lot of awareness. A lot of patients had been through similar surgical procedures, and a lot of times the results were not that good. So I decided I was going to help myself. I was going to find a solution to my problem. And I spent 10 years looking into how I could get myself better using alternative methods. To make a long story short, in 2002, I had discovered two previously unrecognized inherited foot structures that, if you happen to have one of them, it impacts the entire body, including your neck. And so basically, I healed myself. I started using my research on myself, got rid of most of my pain, and I'm sitting here today because of my research.
So that sounds like a pretty good N of one study.
Yeah, absolutely.
So let's just a little bit before we get into your foot types and how and we discuss the interplay between that function and the CNS, and we'll just call them the whole body manifestations of those structures. But let's get into a subject that a lot of us really don't love when we're going through our medical training. I'm referring now to embryology. So we're going to talk a little bit about embryology. And, I have to admit, I was one of those folks. It's like, when I was going through, it's like, why do I have to learn this? I'm going to operate on adult patients. I don't need to know this. And that's back when you're young and more stupid than you are when you're older and less stupid. But, It's kind of like biochemistry. I didn't have much of an appreciation for that other than just having to get through it. But now, when you look into metabolomics and all of the things that are affecting us, it becomes a much more important subject. So it's interesting how things change over one's career. But let's jump into embryology a little bit, because that really is the genesis, no pun intended, of your work and what we're seeing in patients as adults.
Well, yes, in fact, it's embryology and the study of embryology and going into it and spending several years looking into it deeper and deeper to understand how the foot develops embryologically that led to my understanding and discovery of the two foot structures. What I'd like to do is show you some slides that basically describe it. And I'm going to start here with basically the embryo at 30 days post-fertilization. Can you see it on your screen?
Not yet. Let me see if we can get it up there.
What you're looking at right now is the embryo at 1 month post-fertilization. It's about 5 millimeters in length. And where the arrow is, white arrow is, that is where the lower limb bug is going to appear as the embryo develops. I'm now going to go into, and that's stage 13 Carnegie. In stage 17 Carnegie, which is approximately 40 days post-fertilization, you can now see that the limb bug has elongated, and you can start seeing differentiation between where the leg is and the foot bud. This is the foot bud here.
Right.
And what's interesting is that the bottom surface, the plantar surface of the foot, is facing upwards towards the head. This is the plantar surface of the foot right here.
Gotcha.
If we go up to stage, and by that, it's day 40, the embryo is about 1.2 centimeters in length. When we go to stage 18, take a look at the rotation. You see how the plantar surface of the foot has rotated inward towards the other foot.
Right.
And it's gone into what we call supinatus. This is a structural change. It's not positional. It is a structural change, literally a torsional unwinding in the bones, in the cartilaginous tissue that's going to become bone in the foot and leg. And this occurs about day 44 post-fertilization. So again, you can see that happening where the bottom surface of the foot is now unwinding and facing the other foot. If we continue and look at the development of the lower leg, you can see now where the leg is pretty well discerned. You can see the ankle coming about. You can see the foot developing, even the digits developing. And again, I'm going to go back to the other one. You can see where there it is, and that's how it's extended. And that has occurred in 9 days post-fertilization, during 9 days. Going into stage 23 Carnegie, which is 56 days post-fertilization, and the embryo is about 1 inch in length, you can see now both feet in supinatus, both feet facing inward. You notice that?
Right.
Here it is. As it's developing now, it's extending, and there it is post-fertilization. Okay. If the growth of the foot stops about this time and doesn't further develop and untwisting, but just grows in length, that child is born with a clubfoot deformity.
Okay.
And that's what a club deformity is. Okay, I'm going to go to the next slide, which basically shows. Okay, close it. This one's going to show the actual development of the foot. And this is where it gets really germane to my discovery. And here you have a representation of a preclinical. This is representation of a preclinical clubfoot deformity. That's what I call it. You can see the foot basically is twisted inward, and here the other foot would be. So you can see how the foot is twisted inward. We call this supinatus.
Right.
If the child is born, if the torsional development ends at this point and doesn't continue its ontogenetic torsional development, this is a preclinical clubfoot deformity, and the child will be born with that. However, if the foot continues its torsional development, and the heel bone goes through its torsional development. You see that untwisting of the heel bone?
Yep.
And the heel bone takes with it the entire lateral column of the foot. Embryologically, the lateral column of the foot is everything, including the 4 lateral phalanges and metatarsals, the medial and lateral cuneiform, and the cuboid with the calcaneus. It all untwists together. You see that motion? And
yes.
That is torsional. Now, if the child is born with this configuration and the foot ends its torsional development at this point, not its linear development, but its torsional development of the foot, the child is born with what is called a primus metatarsus supinatus, which means the medial column of the foot is twisted inward.
So let me interrupt.
The tail is all
Brian,
down to the hallux.
Brian, let me interrupt you there because I want to get some clarification. So are you saying, or am I understanding that you're saying that the lateral component has a different schedule or separate torsional change from the medial component? And are they at different?
Exactly.
Okay. Are they at different?
Exactly.
Okay. So it's possible and actually likely that this lateral component unwinds, but yet the medial component doesn't. It doesn't catch up.
Exactly.
Okay.
Exactly. And you can see it here. You can see the first metatarsal in supinatus. The rest of the medial column is hidden, but here is the medial column supinatus. Now, if that unwinds, continues to unwind, and it comes down, that's a plantar grade foot. That's a foot that functions linearly, mechanically. There's no gravity-drive pronation that occurs in the individual's walking. Because you can anticipate, if you have this foot structure and the foot is going heel to toe, that medial column will not be on the ground. The foot has to twist inward, forward, and downward to get that big toe on the ground, the metatarsal on the ground. That's gravity-drive pronation. That's why you have abnormal pronation, because of the medial column supinatus. Or if the individual has a preclinical clubfoot deformity, that's a typical flat. It's what we call a flat, I think they call it a flat foot deformity. It's a pes planus deformity. And when that person walks, as soon as the heel hits the ground, they hyperpronate, the gravity-drive pronation, and then it continues to pronate all the way to toe off. So it's a flat foot right at heel contact. But if you have a primus metatarsus supinatus foot, when the heel bone comes down, it's stable. The bottom surface of the ground is on the foot. The bottom surface of the heel bone is on the ground. It's stable. But when the weight comes forward at mid-stance, now you have to row inward and downward to get the medial column of the foot on the ground, which is now taking the weight. And that's what we see clinically. And I'll show you later in some files how that works. But these were my discoveries, and all from understanding embryology. It all came from embryology. And what amazed me is no one ever talked about it before because it's so obvious. It's so plain. So this is a preclinical.
Let me ask you another question so this is all in utero, of course, but there's still torsional changes that occur in early life once the child is born. Is that correct?
There is, but not in the medial column of the foot. Once the child is born, there is either no or very little torsional development, ontogenetic unwinding of the foot.
Okay.
Almost nothing.
Okay.
In fact, I don't believe you have anything. I think once the child is born, the structure, the osseous structure, as far as the torsional relationships, I'm not talking about length and width. I'm talking about the torsional relationship. It's set in stone. The talus is where the unwinding of the medial column starts in the talar head. Once it has that talar supinatus, it's there for life. You can't untwist it. It's there.
So just to recap what you said from the time of post-fertilization until the medial and lateral columns are unwound, and that maybe not the right term, but I think you understand what I'm asking you. That appears to be about 17 days in the development of the embryo or the fetus.
That's correct. It's a very short period of time that determines whether that child's going to have a preclinical a promus metatarsus supinatus or a plantar great foot when he's born. Yeah. It's a very short window of development.
You would think that there'd be before you go on, you would think that with that short of a period for this miraculous torsion to happen, that there would be far more incidents of clubfoot because of something that would maybe temporarily arrest the fetal development or something like that. It seems pretty miraculous to me that this is happening in such a short period of time, and it's miraculous that we're not seeing even more clubfoot deformities. I get the other foot types you're going to talk about have a higher prevalence.
Exactly.
Yeah.
Yeah, it is. There is, by the way, a very high, in my opinion, prevalence of preclinical clubfoot deformity. I saw so much in my practice. Of course, people came to me with problems, so my practice is biased, obviously.
Sure.
There are people with problems. But even the normal population, I would go into the schools and routinely do scanning of children and looking at it. And I was amazed at the number of preclinical clubfoot deformities I would see in children, upwards of 30, 40% showing preclinical clubfoot deformities. It's I find it quite startling, but it's what we have today. Okay, I'm going to go on now to the next slide. And I want to talk about the proprioceptive patterns that occur from these two foot structures. I'm going to start with a normal pattern of gait, of proprioceptive signals being generated. And when I talk about this, let me preempt it by talking about on the bottom of the foot, all these dots you're looking at here represent the mesenteric corpuscles. Namely, they're the ones that are activated when they're touched. Right. And when you walk, you're touching certain parts of the foot, and the corpuscles underneath that part of the foot generate a pattern, a signal, a pattern that's sent to the cerebellum, giving the cerebellum information about where you are in space. So here is a normal or plantar great foot. This is a foot where the heel bone, the calcaneus, and the medial column of the foot have gone through their complete ontogenetic torsional development, and there is no supinatus remaining in the foot. And we call it a plantar great foot. That foot at heel contact, the left foot, comes down basically flat to the ground. And here's the pattern of simulation you're seeing. These corpuscles, this is a pattern that's generated and is sent straight up to the cerebellum. Then at mid-stance, you can see again from heel contact to mid-stance, this is the pattern that's developed and sent to the cerebellum. You can see it's basically in the middle of the foot, not in the arch area, but in the middle of the foot. This is a pattern stimulation that is sent to the cerebellum and tells the cerebellum where you are in space. And at pre-heel lift, as it continues linearly forward, you notice there's no gravity-derived pronation. This is a pattern that's sent to the cerebellum showing where the corpuscles have been stimulated into the big toe and sent upward. By the way, the cerebellum is programmed to think whatever it's receiving from the foot is coming from a plantar great foot. It doesn't know a preclinical from a Rothbart's foot. All it knows is what it's programmed for. And this is what it expects to see. This is a pattern it expects to see when you're walking on level ground. Okay? And with this pattern, in a normal great foot, in a plantar great foot, you have erect posture because the cerebellum is keeping all the weight-bearing joints centered, functioning around their anatomical neutral position. It's done automatically. So this is a pattern the cerebellum expects to receive. Now, if it gets a pattern different than this, it tells the cerebellum you're walking on uneven ground. You're walking up a hill, you're walking canted to the right or to the left, and it will make a postural adjustment. This is, for example, when you walk up a hill, what do you do automatically? You lean into the hill so you don't fall backward. That's coming from the cerebellum seeing an alteration in the pattern stimulation coming to it, so it makes the postural adjustment where you lean forward so you don't fall backward. This is all done subconsciously automatically by the cerebellum. Okay.
Right. Right.
And this is what a normal pattern of stimulation looks at heel contact, at mid stance, and toe out. This is what the cerebellum thinks is going on. Okay.
Mhm.
Now let's take a look at what happens when that's not going on. Here's a pattern of stimulation, a gait, and this is coming from the primus metatarsus supinatus. They call it now Rothbart's foot because I've written about it so much. But this is what we see, and I'm just going to say Rothbart's foot because it's quicker,
It's easier.
if that's okay with you.
Yeah. It's
So
easier.
here it is at heel contact. Then primus metatarsus supinatus foot deformity. It's easier.
Yeah.
Here it is at heel contact. Notice this pattern stimulation is altered. You're walking on the outside of the foot. At heel contact, the foot doesn't come down full heel contact. It's just lateral heel contact.
Okay.
This occurs because the body is subconsciously compensating. And I'm going to leave it at that because that's a whole other concept, whole other discussion to itself. But that's what we see with Rothbart's foot. Then at mid stance, we see this pattern. The weight remains on the outside of the foot. Look at the weight. This pattern of stimulation sent to the cerebellum is very different than what it expects. And then a toe off, we see gravity drive pronation. You can see it there occurring. And you can see how the pattern of stimulation is skewed again. So if you look again at the pattern of stimulation coming from Rothbart's foot, it's skewed from heel contact to mid stance to toe off. That's into the cerebellum, but the cerebellum thinks this is the normal foot. It doesn't know it's a Rothbart's foot. It thinks the ground surfaces you're walking on are skewed. There are perturbations in the surfaces. So what does it do? It makes postural adjustments to handle what it sees as a ground surface that's not flat.
Okay.
And that's what causes the chain of effects in the cerebellum altering the position of every weight-bearing joint in your body. All the weight-bearing joints are altered because the cerebellum is trying to protect the body from falling, walking on an even surface.
Right.
Any
Okay.
questions about that?
No,
Questions?
that's great. I think just to recap what you're saying is that the cerebellum is really unable to interpret anything other than the proprioceptive inputs that it's getting or signals that it's getting. It doesn't know what something's plantigrade or supinated, and so it, like you made the corollary to walking uphill, we automatically lean in so that we maintain our balance. That's clearly a below subconscious. I mean, that's totally autonomic as far as that's concerned. So what you're saying then is these signals then go to the cerebellum, which processes that information and then sends it back into postural changes to compensate for what it's interpreting. Is that a summation?
That's it.
Okay.
Yes. And interesting enough, my research is based on medial column supinatus in the foot.
Okay.
And for years, starting from 1988, when I started on this, I was my compeers basically challenged my theory at that time, saying there is no medial column supinatus. What you're describing does not exist. Prove it. Prove there's medial column supinatus. Well, I could show them the embryological information, but that didn't basically phase them. They said medial column supinatus does not exist until 3 years ago, when three-dimensional, weight-bearing three-dimensional tomography came into being by the European community, orthopedic community here, basically in the Western European community. They actually showed supinatus, medial column supinatus. They showed in the foot the supinatus in the tail, head of the talus, in the navicular, in the medial cuneiform, in the first metatarsal, and the hallux. So now medial column supinatus is factual, which means my theory has been validated because it's all based on medial column supinatus. So what was once theory, my research is theory up until 3 years ago, now is factual. So Rothbart's foot and the preclinical clubfoot deformities exist. Right. Actually, let me rephrase it. Rothbart's foot has been proven to exist. They have not yet done studies on the heel bone to show the supinatus, but as soon as they do, they'll see it there too. So this is no longer theory. These two foot structures exist.
Okay. No doubt.
Although probably 95% of the podiatric community, orthopedic community, is unaware of that fact.
Right.
Okay.
And I've seen those CT renderings. They have the K wires coming out of the first metatarsal. They show, the torsion quite well. Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called STEM Regen, which I take daily and genuinely believe could revolutionize your health journey as well. STEM Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. STEM Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating STEM Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that STEM Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of STEM Regen.
Yes. And that was one of the greatest days of my life when that research came out. It really did, because basically it just validated me what I was doing my research.
Gotcha.
Okay, let's go on to the next one. I want to talk about actually what happens, the postural shifts that occur when we're dealing with this. I have patients coming to me basically in pain, in chronic pain. And it can impact any weight-bearing joint in the body. Interesting enough, the least areas that involved were the feet. It was mainly the knees, the hip, the back, and neck and jaw. That's where a majority of my patients came to me with chronic pain. Rarely did I see a foot in chronic pain. Once I discovered these foot structures and watched how they were causing the foot to go through gravity drive pronation to bring the medial column of the foot down to the ground, the link between posture and that motion became obvious. And what I realized was I had to somehow stabilize the gravity drive pronation to keep it from happening. Because if I could stabilize it and make that patient's foot function like a plantar foot, then the proprioceptive signals to the cerebellum would automatically correct the posture. And once the posture is automatically corrected, the joints that are inflamed will be repositioned into more or less closer to their anatomical or functional neutral position, and the pain will go away in time. That was my basis theory about how to treat these patients. And I started doing that 25 years ago. And I want to show you some examples. Okay, here's a patient that came into me, and she was experiencing a lot of chronic pain. And this is her standing. And you can see basically the anterior rotation of the pelvis, the weakness in the stomach muscles, the protrusion in the stomach, and you can see basically the head forward position, chin shutting out. Then here's a picture of putting your underneath a proprioceptive signal, and this is the change you see instantaneously. Notice what happened. Take a look at the pelvis. Look at the pelvis right here. Look at the back there. Look what happens. It tucks in. You go from a forward rotation to neutral rotation. Look at the stomach muscles. Automatically engaged, stronger. Look at the head position. Back. Again, I'm going to go back to where I was before. Look where the ear is. See how here's the plumb position of the body. Look where the ear is. When you put the proprioceptive signal underneath, look where it goes. That happens in 2 seconds. Instantaneously. What's happening? The signal, here is the proprioceptive signal. Here's the proprioceptive insole underneath the foot. And the proprioceptive insole is nothing more than geometry. I'm building the ground up to the foot. I'm doing it so the foot doesn't have to go through gravity-derived pronation. I don't correct 100%. I correct somewhere between 30, 40, 50%, unless I have to go further. So usually what I measure of supinatus, say there's a supinatus of 10 or 12 millimeters I've measured, I'll put her into maybe a 5 or 6 geometry in that area of the foot to bring it up.
And you mean 5 to 6 millimeters?
Right, all millimeters.
Okay.
What happened with this patient? Within a couple of days, the pain's going away. The inflammation's still there. Takes 12 months to totally resolve, because if you had chronic inflammation for years, that takes time to resolve. But you're shifting the weight back to the center of axis of the weight-bearing joints where the inflammation isn't, and so they feel much better quickly, and then the inflammation slowly resolves. So that's one case, okay?
That's wonderful.
Let me show you another, it's even more remarkable. Okay, typical Down's child. You can see the typical facial expression, the typical posture with Down's child. These are all the different proprioceptive signals I use. When I see a child, basically, I run a series of tests to determine the correct proprioceptive signal. And that's a whole discussion in itself. I just want to say that's basically what you're looking at. Those are the proprioceptive signals. They're just geometry, shapes of geometry put underneath the foot. Now watch what happens when I put her, and watch her face exactly, most specifically. Here's the signal. Look at that change. I mean, I almost fell off my chair when I saw this. That happened automatically. She almost looks normal now. Look, from here, you see a child. You know that's a Down's child. You see this, you don't know. Also, you can see, look at the changes in the pelvic position in the stomach. Look how they tuck automatically.
Dramatic.
I mean, when I saw this, even I was amazed. Absolutely amazed. Now, this is a child. You can't give any input. You can't tell them to do anything. I mean, they don't respond to what you tell them. They respond to what the cerebellum is doing. And you can see the adjustment. And then I heard from the parent, this child was having a lot of spine problems, thoracic, lumbar. And basically, within a matter of a few weeks, the pain was dramatically less and then disappeared. A year later, she was out of pain. By the way, I had the Rothbart's foot. Since wearing the insoles, I have no pain. My musculoskeletal pain is gone for the last, 40 years.
Wow.
Yeah, my wife has the same thing. My wife has a preclinical. When I met her 20 years ago, she was in debilitating pain. She's been wearing the proprioceptive insoles now, 20 years. She has no pain. It's gone. Just doesn't have any.
It's the worst you've ever seen.
Yeah, she had one of the worst preclinicals I've ever seen. Any questions on this, Steve?
No, I think it's fascinating, and I want to get into the proprioceptive orthotic a little bit because, and maybe I'm jumping ahead, but I think this is radically different than our current concept or understanding of orthotics, is that we're going to try to manage the biomechanical abnormality by holding it into a better position. versus
Totally different.
yeah. So would you agree that's a fair summation of the standard biomechanical concept, or am I missing that?
No,
Because
you're right on. And
uh,
it's wrong. It's just wrong.
so
and I want to just do quickly. Okay, go ahead.
So what you're saying is that by just giving the cerebellum the proper proprioceptive feedback, that it will then autonomically adjust these postural positions of the pelvis, the spine, the head.
Globally, everything.
Exactly.
Everything, globally.
Right.
Globally.
Because it doesn't
I wanna
know.
show-
It doesn't know whether it's the ground feeding that or the orthotic that's feeding that.
Correct.
Okay.
Correct. It doesn't care.
Right.
It just acts on the information it's given. It's like a computer. Garbage in, garbage out. Good
Right.
information in, good information out. That's all
Right.
it is.
Right.
No more than that.
No, it's
I want
very
to show you now how this impacts the cranium. I want to go right to the cranial bones
right.
and how this all, and this is where it gets really interesting, because we're not just talking about the peripheral. We're not just talking about skeletal. We're
Right.
now talking about central nervous system. And what we did was a study. Let's see if I can get better resolution so you can really see this. Okay. We took DORA x-rays, digital orthogonal dental x-rays, and to look at basically the frontal plane position of the atlas, malar, mastoid, temporal, and sphenoid. Malar is the cheekbone, mastoid, temporal, and sphenoid. And I, for years, have noticed when I was using these proprioceptive insoles underneath my patients, I would see personality changes. Depression got better. In fact, I can tell you one story that's almost unbelievable. I had a patient who was brought to me that he was undergoing personality deterioration. He used to be a straight A student, played the violin, very gregarious, likable, 13-year-old, came to me, no longer played the piano. His grades went from straight A to straight E. He became hostile. He became unmanageable, and the parents didn't know what to do with him, and they brought him to me. Out of desperation, they brought him to me. Brought him to me mainly because he was having pain in his spine, and that's what he brought him to me for. I put him in proprioceptive insoles. 2 weeks later, he started playing the violin again.
Wow.
His grades started going back to A's. He became very social. I couldn't explain it back then. That was 20 years ago, but I saw this. I knew something was going on. And I saw this not in just one patient, but many, not to that degree, but many. So I knew there had to be some connection between what I was doing in the foot to the cerebellum and what was going on in the central nervous system as far as mentation. I knew there had, but I didn't know what it was until a few years ago when we finally did this study. Here's a study of a patient. And what we want to see, this is right, the center line, the vertical line is called the odontoid reference line. This is a reference line that the sphenoid, temporal, mastoid, malar, and atlas, first cervical, should be at right angles to this line. That is the physiological correct position of the cranial bones, okay, of the cranial bones in the skull. Notice in this patient, stand with this x-ray taken, the sphenoid's off a degree, the temporal's off of 1.75, the mastoid 3, the atlas, the malar. Then I put this patient underneath his proprioceptive insoles, and immediately they retook the x-ray, and look what happened. You see it? Take a look at the sphenoid.
Right.
It was at 89, now it's 90. Look at the temporal, it's 88.25, now it's 90.5. Look at the mastoid, it was 87, Now it's 91.0.
Mhm.
Instantaneous changes in the frontal plane position of the cranial bones. They moved.
Hmm.
If I would have suggested that 20 years ago, they would have thought I was absolutely insane that you could put something underneath the foot and move the cranial bones. But when you move the cranial bones, guess what you're doing? You're changing intracranial pressure gradients.
Interesting.
And the gradients, if you can normalize the position of these bones as close to perpendicular as possible, you're normalizing intracranial pressure gradients. And it has everything to do with mentation and how the brain functions. You squeeze the brain, it's not going to function very well. When you have an accident, a head trauma, and you have perfusion of liquid into the brain, what's the first thing they do?
They drill a
They
hole
get
in your
rid of
head.
the fluid. They
Right.
open up. Why? Because they know what happens if you don't.
Right.
Well, this is what's going on when you have these distortions in the frontal plane, of the cranial bones, these distortions. It's doing the same thing, not to the same degree, but it's doing the same thing. Okay. Now, this is a patient that a pair of proprioceptive insoles were placed underneath them. Okay.
Right.
Let's look at a patient that had orthotics placed underneath them and see what happened. Okay.
Okay.
Okay. Here's the baseline.
Okay.
Of this patient. Okay. And notice basically his sphenoid is at 90 degrees. Temporal bone's not off that far. His mastroid's not too bad. I mean, he looks better standing barefooted, without insoles, than the patient the preceding patient that had proprioceptive insoles underneath him. I mean, this patient basically looks pretty good. Okay. Now, here's the I don't know why they put him in orthotics, but they did. Take a look at the sphenoid. It just decreased 1 degree. It went from a perfect position to 1 degree off. Look at the temporal bone. It went from almost 90 degrees down to 88. Increased intracranial pressure occurs with these orthotics. These are iatrogenic arch supports. This patient is going to be developing symptoms down the line that no one's going to understand coming from the orthotics.
Right.
The orthotics are putting a signal to the cerebellum that's causing this shift.
Right.
This is why you just can't indiscriminately put things underneath the patient's foot.
Right.
To me, it's not just a malfeasance, it's malpractice, in my opinion. Yet this is going on routinely. They're still doing it. And it has to stop because a lot of people are being.
So, Brian, let me ask you this, because, if you looked at this from a skeptical standpoint, you'd say, well, okay, the sphenoid axis went from 90 to 89, and the other one went down to 88.25, and these are not dramatic angular changes, but I think with respect to the cranial bones, a lot of people didn't even think the cranial bones moved or anything. So while it appears that these are very small changes in measurement, in angular change, it in light of what we're talking about, the fact that the cranial bones themselves don't have large ranges of motion, these are probably pretty dramatic changes. Am I mistaken?
They're huge.
Okay.
They're huge. They're huge. These bones maybe move maybe a quarter of a degree. Nothing. They are not meant to move this way in the frontal plane.
Right.
And for them to move takes a tremendous amount of pressure changes. In fact, I don't even know how the cerebellum causes these bones to move. We haven't worked out the process of how this occurs, other than we see it occurring. But this is huge when it comes to what's going on intracranially. This should not happen. You should not see this type of motion occurring, yet it does occur. And that's why you have to be so careful what you put underneath the foot.
Now, I remember looking at something you showed me with the same type of change with the proprioceptive insole versus nothing for the spinal for scoliosis patient, and
Right.
that was tremendously dramatic because you did see a lot of angular change there in contrast to cranial bone changes.
Yes. Yes.
So.
This is an area of medicine that I stumbled on in my research. And as much as I'm telling you, there's so much more we don't fully understand yet. A lot more research needs to be done in this area. But right now, no, there is none being done other than me.
Right.
I haven't seen anyone else take up the mantle and take it any further.
Well,
And
before
I'm hoping someone does.
well, I think that there's a high likelihood of that after they start to hear some of this. So a couple of comments. One is I could remember a couple of patients just off the top of my head that came in and said, "Are these supposed to give me a headache?" And it's like, no, there's no connection there whatsoever. But now maybe there is a connection, and now I realize it. But
Yes, absolutely. They will give you a headache.
yeah. So it was kind of an interesting observation, except I didn't really make the observation at that time. But let's talk about the actual insole, what you're doing. How do you cast the patient for that, or do you simply make? So you make? Yeah. Tell us the process about that, because this is important.
Casting is so inaccurate, it's useless. No casting. What it is, basically, I invented several methods of evaluating kinesiological muscle testing methods that I invented. Much like the insoles, I designed it. And what I do, the patient comes in, and first of all, I have to determine what type of foot structure they have.
Right.
Is it a plantar grade? Is it a Rothbart's foot? Is it a preclinical? Most of the time, it's a preclinical. Once I know the foot structure, I know where I have to put the proprioceptive signals to keep the foot from collapsing. It's underneath the heel. It's underneath the heel, medial wedge. It's a medial wedge going all the way from the tails all the way to the tip of the toe. But the question is, what's the height of that medial wedge? You can't guess. So what I've done is I've designed a test. It's called a leg rotation test. But basically, what I do is I put different figurations on the patient in a reclined position, and I run this test, and the body says to me, yes or no. It's not me determining what to put underneath them. It's the body telling me. It's kinesiology. It's that spooky area of medicine 40 years ago that all of us looked at and kind of rolled our eyes.
Right.
It works. Once the body tells me what it wants, I then do another test, a muscle test, and I put this configuration on the patient's belly, and I do a muscle test and see if they go weak or strong. If they say strong, I know that's what's good for them. If it goes weak, I have to go back and reevaluate. And that's how I determine the proprioceptive signal to put underneath the foot. That's the only way. It's the body telling me. I don't tell the body. I don't determine it. The body tells me what it needs, and that's what I put underneath them. And so I take those dimensions. For instance, typically it could be 6 millimeters in the forefoot and 2 or 3 millimeters in the rear foot with a slight arch filler to allow a smooth transition heel to toe. And that's what the proprioceptive insole is. It's very flexible, but all it is this geometry, wedge-shaped geometry. It's not cubical. It's not rectangular. It's a wedge shape. The high point on the inside tapers to nothing on the lateral side of the first metatarsal, doesn't encroach on the second metatarsal, because remember, we're dealing with the medial column of the foot. You put information underneath the second metatarsal, you're going to get a response, a nightmare response. You have to be very careful where you put the stimulation. It must be under the medial column of the foot, no other place.
And what's the nightmare consequence if you get too far lateral?
You will send information to the cerebellum and your guess is mine. It will cause changes in their eyesight. It goes on and on and on. You have to really, really respect what these things do. They look so simple, but they can create havoc if they're used inappropriately. That's why you have to be trained in how to use them and not just go to a 3-hour workshop and then start putting them underneath people's feet.
Right. Right. Well, that's going to lead to the that's going to lead to the next question, is where can people get training in this? Because I think that you and I talked about this yesterday, and that might be something that we have to think about in the future.
Unfortunately, the only person that's training is me. And no one's been interested to be trained, but I am willing, if people will come here, I'm willing to train them. And so they can go on and train other people.
Well, before you tell them to come and see you, tell them where you're at.
I'm in Portugal.
Yeah, there you go.
Central Portugal.
There you go.
In the mountains.
They produce some wine up there, I understand.
Wonderful wine, but personally, we don't drink wine. But yes, I'm told the wine is superb.
Yeah, it's great. Awesome. So let's just talk about some general stuff real quick, because I think the presentation you gave was just fantastic. I think it creates a lot of thought, because this is so contrary to what we're traditionally taught in our 1 year of biomechanics. So it's a radical change. It's going to take people some time to, first of all, they've got to be open-minded to look at something different than what they've been trained. And most of our listeners are very open-minded, and if you can show them evidence, they tend to want to, look at it even a little bit more, get down in the weeds, so to speak. But what kind of pushback have you had trying to introduce this over the last 4 or 5 decades?
Oh, God. I don't know where to begin. I talk to my compeers on the podiatry, and I've been on that forum for 15 years trying to talk to them about what I'm doing. And they will not discuss my research. What they will discuss is, oh God,
Our personal life.
my personal life,
My
wife, why I moved to Portugal, why other podiatrists don't like me, find my work offensive. Just a couple of things. I lost my license in Washington State doing this work, basically.
Wow. Okay.
I was told, with surgery, you're okay. You do this work, you're not going to be here. It was on the side. I was just told that on the side. Well, I said, hey, I'm going to do this work. It's my research. Well, I lost my license. They brought about a case against me, 3 people against me. One of them said that I refused to treat her. She came to my office and I refused to treat her after starting therapy, and refused to continue it. But the bottom line was I never saw that patient. It was in a seminar I gave at another man's office, and some lay people came there, and I talked about my theories, and she was one of the people, and she came to me and I told her I couldn't treat her, and that's what came from that.
Wow.
That type of thing. So that's what I've been faced with for 40 years. Basically, a lot of harassment, a lot of threats, told, do the surgery, don't do what you're doing. Cut off a foot, you won't lose your license. Do what you're doing, you're going to lose your license. And that's where it's been continuously. And in fact, if you go on the podiatry forum, I'm hated there. They really hate me for talking about what I'm talking about, my research. It makes no sense.
That's pretty sad, actually, and we saw a lot of that in the recent COVID disaster with retraction of articles and all of this and that. But I think what people and really what I failed to understand before COVID was that the journal process, the peer review process, it's corrupted. I don't want to get into the conspiracy theories and all of the tinfoil hat stuff, but it's not pure like I thought it was. I thought science and medical literature was maybe the last bastion of pureness and truth, but we know that's not the case now, and it's a sad thing. So, anyhow, wow. Anything else you want to bring up before we wrap up? Because I think this is a great discussion, and I really appreciate you taking the time to share your work. And I hope that your work gets more acknowledgement, because I think that
my wife asked me to say one more thing.
Okay.
I wasn't going to mention it, but basically, in 1999, when they were coming after me and suing me for malpractice, I went to a lawyer and I presented what was happening. He said, "Brian, you have two choices. Do you have 250 to 500,000 dollars available to fight this? Because we'll win it." He says, "If you don't have it, you better leave the country."
Wow.
Because you're going to end up in jail if you don't. We left the country. That's why I'm in Portugal.
Wow.
That's the short version of it.
Well, thank you for sharing that. I'm astounded, but not surprised. Let me just put it that way, because it's tough to be an innovator and to challenge very deep entrenched dogma and paradigms and to shift those and to destroy that dogma. Not such an easy process. So I congratulate you for that and your work.
Hopefully we can change it. Hopefully we can get young researchers involved, that they'll take this work and expand on it and take it to a much higher level than it is right now.
No, I agree. Dr. Rothbart, thank you so much for taking the time with us today. It was an honor for me to learn from you, and I look forward to learning more.
Well, thank you for inviting me. It was my pleasure.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.